So using my little cartoon here, what I'm indicating is that the mean number of patient results between failures is telling us how long we're going along, how long we expect to go along in an in-control state before something happens. We can use ENU, enough and enough, to tell us something about predicting the number of unacceptable, unreliable results we expect when an out-of-control condition occurs, given the type and magnitude of the out-of-control condition. And then if we take our assessment of the flu, the probability of harm given an unacceptable result, and multiply it by the expected number of unacceptable final results, we have an assessment of the number of harmed patients. Now notice in between, in the post interval there's one little asterisk that's flashing. The reason I did that is the idea here is that was a result that would have resulted in patient harm if it got reported. Whether or not it does result in patient harm kind of depends upon whether you're doing bracketed QC, in which case it wouldn't have gotten reported, so it wouldn't have resulted in the harm, or whether or not you're able to, if you're immediately releasing results, whether or not you're able to recognize that you've had a problem and correct it before harm results from that, okay? So I'm going to assume that we do a good job and that one doesn't cause a harm. All right. So the probability of patient harm is the expected number of patients harmed due to incorrect results from a failure mode. That's the two black asterisks here, divided by the average number of patient results examined between failure mode occurrences. This is our defect rate. The denominator is the number of opportunities, the number of patient results that we report between failures. The numerator is the number of harmed patients, our estimate, our prediction of the number of harmed patients resulting from that failure. Okay? So we have my one equation, a simple little equation here. Probability of harm, it's really a ratio. The numerator is the number of, our estimate of the number of harmed patients resulting from the failure mode, and the denominator is how long we go between failures. This is a way of, not that complicated a way actually, of trying to get at a defect rate. Not complicated with help. You should expect help to compute those things. You know, get a computer program and push some buttons and it computes it for you. So estimating probability of harm, we don't have to give up and just drop in this box once a week, once a month, once a year. We can do better than that. We can get at something that's more quantitative than that by combining risk management activities to help us get rates of occurrences for failure modes, not rates of occurrence of harm, but rates of occurrence of failure modes, and the probability of harm from an incorrect result, and combine that with statistical QC design, which will help us estimate or predict the expected number of incorrect results that are reported when that eventual failure mode occurs. So I've made the case now that we can estimate risks for these things. So in the first column, the rate of occurrence of failure modes, I've shaded them in blue and green. The blue is the risk management, the green's the quality control design. We said that we can get an idea about the rate of occurrence of failure modes from manufacturers' information, from technical bulletins, from product alerts, et cetera. Number of incorrect results reported when a failure mode occurs, we can get information about that from our statistical QC design and evaluation. And the probability of harm from an incorrect result, we can get information about that from the literature based on medical judgment, consulting with our clinical colleagues. But what about, so estimating is nice, but what about trying to do something about the risk, about trying to reduce the risk? What kind of abilities do we have there in the laboratory? And Jim's already alluded to this. For rate of occurrence of failure modes, I would say that we have some ability in the laboratory to reduce the rate of occurrence of failure modes, at least those that are related to the lab environment and lab processes. So we can do a better job of training. We can make sure that all of our specimen processing and specimen storage and those kinds of things, that we're trying to minimize the opportunities for things to go wrong. When it comes to the medical devices themselves, as Jim has said, really we have very little opportunity to do anything to modify the risk characteristics of that. That's what manufacturers do. That's what they're all, for them, what risk management is all about is that part. It's trying to identify and reduce all the different ways all the different opportunities and ways that their instrument can fail. And about all we can do is follow their instructions and maintain the equipment well so that we don't increase the risk over what would be claimed, but we really don't have much ability to reduce it any further.